Hello friends. So today I'll be talking on this 48th COVID-19 update. This is 1st May 2021. So the topic is on JAK inhibitors in COVID-19. So this is in the context of a new molecule uh, study that came in recently in Mayo Clinic's proceedings. So if you recall, we had covered on baricitinib in 39th update. So I'll just take you because baricitinib was earlier a JAK inhibitor that was tested and it was published in NEJM. And this update I had done in on 39th update sometime during November 2020. So I'll just take you very quickly through the findings of this baricitinib because that would give you a good context as to whether there is some merit in using or considering this tofacitinib molecule. So if you recall, so this particular update I had done on 16 December 2020, when this trial had come out in NEJM on 11 December 2020, where they tested the role of baricitinib, whether it had any beneficial effect, along with remdesivir. So this was a hugely positive trial, and it raised a lot of enthusiasm about this new molecule. But by then, in December, our COVID cases had significantly come down in India. So possibly there was not much of interest we took in this molecule. But now with this raging pandemic and with a lot of deaths happening, so it's worthwhile revisiting this drug, whether this can help in save lives in our nation and reduce our fatality rates. So this baricitinib trial, which came in December, it was a double-blind randomized controlled trial where they compared one group which got remdesivir in the standard dose. They got 200 mg on day one, followed by 100 mg once a day for 9 days. So for a total duration of 10 days. So this was compared with a remdesivir group, which also got baricitinib. So the primary outcome they looked was to look at time to recovery on a 8 scale ordinance scale. So 8 category ordinance scale. So all the COVID studies, if you see, they grade the improvement in the symptoms on the 8 category ordinal scale or 7 category ordinal scale. So the secondary outcome was to look at day 15 clinical recovery. So what is baricitinib? So this is a JAK1 and JAK2 inhibitor, so which is a Janus kinase inhibitor. By inhibiting this Janus kinase, there is an intracellular signaling transduction that happens, and that gets inhibited, and the production of all these inflammatory cytokines tends to happen because of this extensive intracellular signaling transduction that happens. So because of inhibition of these receptors, this activation of these signaling pathways are interrupted, and the production of these inflammatory cytokines, predominantly IL-2, IL-6, interferon gamma, and granulocyte colony stimulating factor, are mitigated. So that's the mechanism of action. So another important mechanism of action of baricitinib was it impairs the AP2 protein kinase, and by doing this, it prevents the entry of virus into the cells. So this is the proposed mechanism of action, and it does cause increase in the lymphocyte count as well, because we understand in severe COVID, lymphopenia is a bad prognostic marker. So this JAK inhibitor baricitinib increases the lymphocytes. So there were 3 case series prior where they have trialed this baricitinib, and they found it did improve oxygenation and reduce the inflammatory markers. So one of the study came from Spain and another came from Italy and USA. So this was a very robust study. It came in NEJM. So it was conducted across 67 trial sites. So predominant sites were in US 55, followed by Singapore, Korea, UK, and Denmark and Japan. So these are the trial sites where the study was conducted. And the study was conducted between 8th May 2020 to 1st July 2020. And as I said, it is to compare one group which only got remdesivir, another group which got remdesivir along with baricitinib. So the dosage of baricitinib they used was 4 milligrams, 2 milligram twice a day for 14 days. And they used a 2 milligram once a day if the estimated GFR was less than 60 ml per minute. So in the results, the median age was 55.4 years, and as in any COVID, 63.1% were males. So the important aspect of this study, which one should take a note, and all the listeners, is the steroids were not a part of standard treatment. So one could argue now with the advent of steroids as a standard of care following the recovery trial, whether there is any role for baricitinib. So this was the argument we made then in December, that possibly there may not be role. But now this second study, which came from Mayo, has compared the group which got steroids with JAK inhibitors as opposed to the group which got only the steroid group. So that's the limitation of this particular study. Steroids were not part of the therapy. So they had 706 patients in the ordinance category scale of 4 and 5. So 4 and 5 category is patients who are in the hospital. They may be getting supplemental oxygen, and the ordinance scale 4 is where there's no oxygen, but there is ongoing treatment. And there were 327 patients in the ordinal category scale of 6 and 7. 6 means they were on NIV and HFNO. 7 means they were intubated and mechanically ventilated. I'll just quickly take you through this study. So if you want the detailed version of this, please visit the website to look into the 39th update. So 1,033 patients, 515 were in remdesivir and baricitinib, 518 in remdesivir. So as you see, the time to recovery was much earlier where baricitinib was given, and that was statistically significant. And the time to recovery in patients who were on HFNC and NIV also was significantly lesser in baricitinib group, 10 days as compared to the 18 days. And improvement in clinical status at day 15 was 30% higher in the baricitinib group, and 28-day mortality was also significantly was less in baricitinib group, but that did not attain statistical significance. Serious adverse events were significantly less in baricitinib group, and the new infections also were significantly less in the baricitinib group. So they looked at a lot of secondary. I think the secondary outcomes were very impressive in this particular study. They looked at ordinal scale 5 and 6, and they saw the day 15 clinical improvement happened much better in the baricitinib group, and that was statistically significant. And the median duration for change in one ordinal, which means patients improving from ordinal scale of 6 to 4 or 4 to 3. So the change, the median duration for the change to happen was much lesser in the baricitinib group, and that was also statistically significant. And the patients going on to needing new oxygen was significantly less in the baricitinib group, 22.9 versus 40.3. And the patients going on to needing mechanical ventilation and ECMO also was significantly less. So basically, if you look at these secondary endpoints, very, very significant and very striking that it had a positive effect in all these endpoints. And they looked at patients who are on intubated and mechanically ventilated or who are on ECMO. So the duration of the patients on these mechanical ventilation or ECMO also significantly less in the baricitinib group. So all in all, so the baricitinib, really this study showed us that baricitinib seems to have a huge beneficial effect. Albeit we need to remember there was no steroids, because at that point of time recovery trial had just come in and had completed this trial. So steroids were not part of this. So you could look at this study as baricitinib having an anti-inflammatory effect akin to how the steroid works. So that's the sort of conclusions we made when we presented this. So remdesivir with baricitinib as compared to remdesivir alone was found to be superior in reducing the time to recovery and accelerates clinical recovery in patients who are on HFNC and NIV, and it did reduce the serious adverse events. And the whole key secondary endpoints of improvement in patients with ordinal scale of 5 and 6, and the median duration of one ordinal scale, and patients going on to needing oxygen or mechanical ventilation was significantly less in the baricitinib group. So this was the conclusions we made when we spoke about this article. So let's now, in the 48th update, look into this article which is a preprint article to be published in Mayo Clinic Proceedings. So it's an anti-inflammatory treatment of COVID with tofacitinib, which is also a JAK inhibitor, or alone or in combination with dexamethasone, is safe and possibly superior to dexamethasone as a single agent in predominantly African American cohort. So this was a US study. It was a single center retrospective observational study. So this may be the limitations of this study. This is not a randomized controlled trial. It's a retrospective observational study conducted between 1st March to 30th September 2020. And the study was predominantly done only in one center, which is Delta Regional Medical Center in part of USA. So the primary outcome, they looked into hospital mortality, So this is not a very robust study. There's no robust statistical analysis or anything of that sort that's done. So it's a simple, straightforward observational study. So the background authors quote that the autopsy in patients with COVID who have died of ARDS shows the cells have being infiltrated with lot of inclusion bodies and vacuoles. So there are a lot of viral inclusion bodies within the alveolar cells, and there was extensive inflammatory cells in the in the cells of the lung that were that were affected with COVID. And interestingly, they found autopsy report showed a lot of microthrombi in the vessels, in the alveolar vessels as well. So this was the typical autopsy findings. So a lot of inclusion bodies within the alveolar cells, and there was a lot of inflammatory cells, and there was a lot of microthrombi formation. So this is a typical autopsy finding that they found. So now let's understand. So we saw how the baricitinib acts. So tofacitinib also acts very similar. So the way it acts is, so any immune cell, it has around 4 JAK receptors, Janus kinase receptors. And these receptors, when they undergo phosphorylation, it causes activation of the signal transduction mechanism. So these are the signal transduction molecules which activate the signaling pathways within the cells. And it also activates the activators of transcription as well following the phosphorylation. So there is a phosphorylation of the Janus kinase receptors, which leads to the whole activation of this intracellular signal transduction and activators of transcription. So what this leads to is this whole signal transduction that gets activated modulates the expression of certain genes. And modulating this expression of the genes lead to the production of lot of inflammatory cytokines. And you see the numbers, there are a lot of interleukins that get released following this activation of the signaling transduction that happens, and by modulation of the genetic expression. So basically, the tofacitinib blocks this phosphorylation and inhibits the release of all these inflammatory cytokines. So this is the mechanism of action. But some of the serious adverse events of tofacitinib that is identified is the possible risk of these drugs causing malignancy. So the FDA does approve the use of tofacitinib in COVID, citing that because this is used for a very short duration of 7 days to 10 days max, so the risk of malignancy is possibly not much at all, is what the authors have described. And another important adverse events of these JAK inhibitors, or they can create a prothrombotic state. So they can cause venous thromboembolisms. But the authors do subscribe that because these COVID patients who are at a risk of these microthrombi, they are either anticoagulated or they are on prophylactic thromboprophylaxis. So all this would negate the risk of these microthrombi formation or the venous thromboembolism as a risk factor or as an adverse events of tofacitinib. And tofacitinib also can cause immune suppression because it does blocks this phosphorylation of these receptors, and so it does lead to immune suppression. So obviously one has to keep an eye when you're using these drugs for any secondary infection that may have set in. So these are some of the side effects of tofacitinib. So coming to the study, so they had one group which got tofacitinib with dexa, and it was compared to another group which got only dexamethasone. So the dose of tofacitinib that was used was 10 milligram twice a day for 5 days. So they had 269 patients. So 138 patients were in tofacitinib along with dexa, and 131 who received only dexamethasone. So when you look at the mortality, it was strikingly less in the combination group, tofacitinib with dexa, 31.82 compared to 68.1. That was significant. And when they looked at absolute terms, there was 70% reduction in the death, and the odds ratio was 0.38. And as you see, the confidence interval is statistically significant. They looked at the infection risk because we did consider the infection risk would be more in the JAK inhibitor group, but there was no difference in the infection risk between tofacitinib group and the dexa group. The bleeding risk was slightly higher at 2.5%, and authors did attribute this to anticoagulation these patients were on, but none of these bleeding episodes were life-threatening is what is is what is documented. And hyperglycemia, as expected in all studies, was more in dexamethasone group. So the limitations of this study is, as we understand, it is a retrospective study that becomes a very important limitations. And some of these patients did receive tocilizumab, and the effect size of this tocilizumab, whether this had a favorable influence on the tofacitinib group, one would not know. And authors have not given the numbers as to how many in the tofacitinib group got tocilizumab and how many in the dexa group got tocilizumab is not described through in the whole of the manuscript. This is a pre-proof article, so maybe once it's published, we may get some information as to how many of the patients got tocilizumab. But some of the patients did get tocilizumab. At this point of time, we do not know which group had more of tocilizumab recipients. And in this study, another important thing is there's no rigorous documentation of comorbidities and so forth. So that is another important limitations of this study. So this is the Kaplan-Meier curve where you see the survival. The blue one is the tofacitinib. Survival is significantly better with the tofacitinib with dexamethasone as compared to only the dexamethasone group. So now to conclude, we could sort of subscribe. There are two back-to-back studies looking at the JAK inhibitors. Obviously, the first study, the baricitinib, is a much robust study which came in NEJM, where they have really done a very elaborate study over 55 centers, double-blind, randomized controlled trials, and they looked at various endpoints. That was very impressive. But the only limitation of that study was they did not get steroids in that. Steroids was not part of the standard of care. But this tofacitinib study, it's not a robust study, it is a retrospective study. But again, there is strong signals to say that adding tofacitinib to the dexamethasone did have a favorable effect on reducing the mortality by up to 70%, which is strikingly impressive. And the infection risk was no greater in tofacitinib group. So we need more randomized controlled trials. So right now, friends, for conquering or vanquishing this pandemic, the approved or accepted therapies are only threefold. So antivirals is one of them. So possibly remdesivir may confer some benefit. The second one is anticoagulation, where we see patients who are at a much higher risk of this microthrombi formation. And the third important dimension of care is the anti-inflammatory therapy. So now recovery trial has clearly shown us an indication that steroids are there to help. So adding now a JAK inhibitor in addition to the steroids, so may hold promise. So if any of us are using this tofacitinib, which is easily available in India, and it is much cheaper as well. So it is good to document and do our own observational study to see if it is making difference comparing to the historic cohorts. So that's what I'm intending to do in my hospital. And it's not very expensive, because I just found out today it costs 333 for 10 tablets for 5 mg per tablet. So which means it's not very it's not cost prohibitive when you compare this with MAPs like tocilizumab or itolizumab. So all in all, there are signals indicating that this drug may help in mitigating the inflammation. So I would leave the listeners to make their conclusions and interpret it if they wish to use this in practice. And then obviously when anyone is using it, I would sincerely urge them to document and do some sort of a study and publish it so that we can learn from each other. So thank you all. So I end with this important quote: in allowing me to attain what I have done, God has made of me merely an instrument of his own will for the revelation of his own divine power. So this was told by a Nobel laureate in physics, Marconi. So thank you all.